questions such as what can we prevent, how do we get there, and is what we are doing working and for whom. So there are different ways you can understand systems. Metaphors, for example, onion metaphor or metaphor of a lake. You can also have maps, so spatial maps looking at the distribution of health disparities in the US, or a map like a causal map, like the Foresight map on obesity. And then also formal models of systems. And these can include statistical models, spatial models, social networks, as well as computational models, including simulation models. And there are a number of different techniques people use there. I'm going to focus specifically on system dynamics because that's has a set of visual conventions that allow group model building to develop and provide some context. There are a number of different definitions for system dynamics, but this is the one I use a lot, drawing on my colleague George Richardson, who is reviewing the foundations of the field of system dynamics and Jay Forster's work in particular. And what he emphasized was that there were these four pillars: endogenous or feedback perspective, the idea of stock or level variables representing accumulations, flows, and then the last bit here being the use of computer simulations. This is a hierarchical list, so the fact that this is at the top of the list is an important feature. If this list were reversed, it would probably be much harder to think about how we engage stakeholders and communities in group model building. Just to provide a little bit of context here, we have, in terms of system behavior, you usually think about this in terms of time. So this is an example of looking at changes over time in terms of the status quo and the desired being in dashed, looking for lead exposures and testing for children in Cleveland. And so this would be an example of trying to change the dynamic behavior, basically trying to change it from the status quo or business as usual to some desired pattern, both in terms of testing and reduction of blood levels. We do that through informal maps. So these are there are two different conventions in group model building that we use that are fairly standard. One on the left is causal loop diagram, and one on the right is the stock and flow diagram. They are visual conventions that allow people to conceptualize a system. Both of these are drawn by participants in workshops without any formal training in system dynamics. The one on the left is parents and grandparents talking about what it takes to raise a child in St. Louis. This was the second out of 3 sessions. They had about an hour for each session in terms of actual working time. And you can see that there's a set of feedback loops here, for example, from education to employment back to education. The one on the right is the stock and flow diagram. This is work in Honduras through the Inter-American Development Bank, supported by Gates Foundation, Carlos Slim, and Government of Spain. And here you see the boxes. They represent accumulations or different stages of decision-making related to where to deliver a baby, and they have also mapped in the interventions. So these are informal maps. These can also be converted into formal simulation models. So this is the work in Honduras at a later stage, showing a causal loop diagram representing the simulation model, looking at maternal and neonatal mortality, and strategies to reduce mortality rates and different interventions that are broken up by different types of services, both supply side and demand side and quality. And for something like this, you can then look at combinations of different interventions from the base case, meaning if we leave things as status quo, there'll still be an improvement, to the best case in terms of the model. And then by looking at these various combinations, being able to identify insights. In this case, this helped us identify an approach to quality improvement that ended up being called Quality Improvement Plus, focused specifically on institutional delivery. The benefit of having people involved in the process of group model building is this is the actual diagram that, for example, stakeholders and Vice Minister of Health were using to explain why these results and these interventions were working as they are according to the model. So by building that capacity up within the workshop among the participants, in this case, policymakers, the intervention was able to, we were able to focus fairly quickly. So I want to now shift. So in this particular case here, the thing I want to stress is these structures tend to be much more sensitive in terms of the behavior of the systems tend to be sensitive to the structure more so than the parameters, even the initial conditions. And so that means it's really important to have actors in the system who are understanding and working day to day accurately represent the system more so than the modeler or the outside expert, which is what brings us to group model building. So group model building, short definition is it's a participatory method for engaging stakeholders in model building. There are a number of different reasons for using group model building. One is being able to see the system together as a whole, sharing system insights. So it's not, I've had plenty of experiences in workshops, for example, where there are some folks who are very familiar with the system, but out of 30 people, they might be a minority. And so the challenge is not just understanding the system, but being able to communicate clearly and persuade your colleagues, other community members, some of the system insights that might be counterintuitive. One participant early on in this line of work talked about this in terms of dignity of risk. Specifically consumer mental health services, and came up after the workshop and basically said, look, these policies are going to affect me whether or not, that they're going to affect me whether or not they work. This was the first time he had a sense of actually having people in the room who are starting to understand the complexity of his day-to-day life as he was working through the system. And then lastly, you can think about group model building also being an intervention. So there are lots of examples in this line of work where people develop a system insight, and that's enough. The system changes. I'll talk a little bit about that in some of the examples with the Foundation for Ecological Security. This is an example of a workshop also in India that we did. This was led by my colleague Ellis Ballard, who's the director of the Social System Design Lab. In this case, adapting some of the conventions and tools to make sure in terms of addressing issues around literacy. So there are pictures that represent variables, there are stones that represent dots, and then people are sort of working through this causal map. So when we're using the term group model building, it's important to put it in the context of that there are many different ways in system dynamics where we may engage stakeholders. So that's always been part of the tradition, including ethnography, conformant interviews, focus groups, workshops, and so forth. Out of this, beginning sort of in the mid-90s to the present, there were a number of different approaches, including group model building, the Albany tradition, George Richardson, David Anderson, group model building, Nijmegen tradition, primarily Jack Benix, and then Etienne Rouet. And then Barry Richmond was famous for his strategic forums. From there, Chris Stave did a lot of work in environmental systems and continues to do so. And she would draw a distinction between group model building and participatory systems modeling, in part because the group model building tradition out of Albany is focused on a project and always building a simulation model to support the decision-making, whereas the work that Chris would describe and do often involved a workshop, but it might be more conceptualizing a system, and then in a later stage involve building a simulation model. And then in the work that Gautam Yadama and I started developing around doing this in community context with organizations like FES, that became an approach called community-based system dynamics that drew on both traditions. So when you're using the term group model building, just to be aware, some folks will want to use it and in a narrow sense and refer specifically to the intention to build a simulation modeling. So that would be group model building Albany tradition. Many today would include both group model building and Albany tradition, also the Nijmegen tradition. And Jack Benix was very clear that you don't necessarily always go to group model simulation modeling. Qualitative models may be sufficient, and was very focused on also some of the features, for example, developing consensus. And then I would say today, realistically, we're talking about group model building in the broadest sense. And I think some of the work that Patty and Valerie will share is really exemplary in that sense, in being able to expand and apply it in novel ways. This is a terrific paper if you're looking for sort of a different review of the different traditions. sometimes people make the distinction between group model building, participatory system dynamics, and community-based system dynamics. And I'll talk a little bit about community-based system dynamics now. So I mentioned this is work that developed originally through work with FES, and also Rittner School District and West End neighborhood through a high school program in terms of changing systems, where we had high school youth design and lead these workshops over a period of time. And to me, what stands out in terms of the distinction between something that's more project focused versus community focused is this idea that when you're doing these workshops over time within a community context, you're building capacity over time. So for example, with changing systems, we started on the topic of racism in 2015. This was a request by the community. At that point, we already had an established relationship. Then 2016 was gun violence, 2017 youth homelessness, education equity, and finally emotional support in schools right before COVID. And what you see on the left are different skills from and activities that are used in group model building, from hopes and fears, graphs over time, connection circles, causal loop diagrams, up to simulation. And what would happen is, for example, in 2016 going to 2017, some of the high school students would say, well, we know we can build simulation models. I think we'd like to see a little bit more of that. And so if you got into that, and then the next year more wanted to get into that. And by the time we're at 2019, actually, not that everybody wanted to do the simulation, but everybody wanted to learn. And so you're sort of building that capacity and interest. And these are high school students that are participating in multiple years. In some cases, their younger siblings came in, and then their younger siblings came in. So that was pretty neat. This is an example of the results also from Raised in St. Louis and the work we did in Social System Design Lab. This would be an example of a causal map at a later stage. This was the third workshop, where you're now looking at the synthesized results as well as the areas that this program is going to focus on. And then from here, participants identified what would make each of these services meaningful. That was used directly to inform the program evaluation and implementation and the advisory board. The most recent work that's directly relevant to some of the things we'll probably be talking about is the use of group model building for selection and tailoring of implementation strategies. And this refers to some of the work that Byron Powell and others have led. We have a project looking at implementation of clean cook stoves and specifically clean energy stacks. So this is work also in India with FES and Boston College and WashU and Case Western, where on the left you see a preliminary structure looking at implementation and de-implementation, implementation of clean fuel, de-implementation of the coal and wood. This would be how we would implement some of the strategies and sort of the mapping of some of these strategies from the community sessions. So there are interesting things here that came out, for example, endogenizing distribution, and also the role of gender equity and ways that women would be able to shift the use of the fuels. So let me close with a couple of reflections on this in terms of having done this for now quite a while. People often look at group model building, as particularly in community context, and talk about, well, it seems very complicated. I think the experience we've had, and every time I've been in workshops and communities, I just came back from a trip where we're doing group model building in American Samoa. People worry about this question. It seems very, very complicated. But the statement that comes up again and again is for most of the communities where we're doing this, complexity is a fact of life. And there's real value to being able to have that complexity reflected and having others being able to share knowledge and identify and mobilize resources. And that's held true whether we're talking about high school students, communities, cancer survivors. I think there's an important point here that engaging community is an intervention that has both valued tangible and intangible benefits. Things like being able to see hope, being able to see solutions, being able to identify and acknowledge that there's a system producing these outcomes all has important intangible benefits, and then the opportunities to recognize and leverage the tangible assets in a community is a major strength. There's a term I've used over the years, really speaking to the structural empathy. So knowing that others understand the structural complexity of a situation is a powerful, and it's been really a privilege when communities are sharing their stories and seeing that happen. And then lastly, I get a lot of flack, mostly from my colleagues who are more academic and researchers, about this is going to be too complicated, too difficult. But I feel very strongly about this belief that people can learn to model and use these models effectively. And I've seen that again and again. And I don't think we're doing anybody any service by assuming people can't do this or it's too complicated. So I'll end there and turn it over.
Great.
Yeah.
Go ahead.
No, thanks, Peter. So Patty, you take it over. Thank you.
Okay, great. I'll take it over and then we'll have questions at the end. I couldn't agree with everything that Peter said more strongly. And let me just see if I can get my screen sharing in the right mode. Okay, are you seeing my presentation view or my notes view?
Your notes view.
So let me swap displays. Okay, now better?
Yeah.
Okay, perfect. Okay, I'm going to try to go through these fairly quickly so that I can give Valerie some time to kind of talk about the exact point that Peter was just making, which is that this sounds to most academics as overly complex, overly complicated. We never will be able to do this in the time frame that we have. I've heard the same thing. And I really want to say that we backed into group model building by trying to figure out what have we actually done. And then I stumbled across some colleagues who knew of Peter's work and said, well, we were doing that. We just didn't know that's what we were doing. And I think that's one of the core lessons that I've learned going from molecular epidemiology to implementation science, which is that, you know, a lot of this is common sense, but once you can put some theoretical structure behind it, it actually can be sustainably helpful. And so what we're going to talk about, Valerie and I, are group model building and mixed methods research. So how do we weave this into a broader kind of perspective of what we're doing? And I just want to start by acknowledging that, of course, when you're doing this kind of work, this is, you know, these are very large teams of both, you know, investigators, research associates, and sorry, and then large stakeholder groups on the ground. So this is truly embedded implementation science and participatory. We had many partners throughout Peru that we gained over time as we kept working, and Valerie's going to hopefully tell you a little bit more about how we're trying to sustain that. So the context of our application of participatory group model building, it was, we were working in Iquitos, which is in the Peruvian Amazon. Iquitos is the largest city there. One of the things that's remarkable about Iquitos is that it's one of the few cities, if the only city in the world, that's only reachable by boat or by plane. You cannot reach it by a car. And one of the things that we saw in Iquitos is that cervical cancer remained the first leading cause of cancer death among women 15 to 44 years. And that was despite the fact that many, many different surveys that had been provided showed that women were getting PAP screening or VIA screening. So we knew that there was a particular problem there. We engaged with the largest public health network in Iquitos City, Peru, which is the Microred de Quito Sur, or the IMRIS. They had a population of about 20,000 women who were 30 to 49 years old, who were able to be screened by HPV-based testing, which I'll talk a little bit more about why we chose this. And this is just an example of the primary health facility in the Peruvian Amazon, which may be familiar to many of you who work in rural areas, of where most healthcare and most cancer prevention might be best applied. What we did was to bring together the Microred de Quito Sur to ask whether they could change their screening system, which was apparently not preventing cervical cancer, to something that could be better aimed at meeting the recently applied WHO cervical cancer elimination initiative goals. 90% of girls fully vaccinated with HPV vaccine by age 15 years. This was something that the country was already doing. And so what we really focused on was how can we get 70% of women screened by a high performance, highly sensitive HPV test, at least by 35 and 45 years of age. And importantly, and this cannot be overemphasized, of those who screen positive, have at least 90% of them appropriately managed and treated. And so we looked to say, how could we do this, right? And again, we felt after reading a lot of implementation science, well, this, we saw the theories, models, and frameworks, and we thought, this is a really complex problem. And I don't know that I can take one theory or one framework or one strategy and believe that I could, fundamentally change this complex system, which included, unlearning some things that were not working for them, such as pap smear, colposcopy, and then relearning and introducing and implementing some newer technologies and whether those would even be feasible. And so we took a systems thinking approach, which we have described, and I have the paper reference here, as the Integrative System Praxis for Implementation Research, or INSPIRE, an implementation methodology to facilitate the global elimination of cervical cancer. And this is a system that starts with defining the problematical situation, which we defined as, despite the fact that women were being screened at reasonably high rates, close to the cervical cancer elimination goals, at least as stated by the ministry, the cervical cancer rates remained really, really high. And then we wanted to launch the project to say we could improve that if we understand the system together with the stakeholders who are involved, who influence, or who are beneficiaries of the screening system, find leverage based on that understanding of what we can change to do better, act on that shared decision, and then learn and adapt through creation of learning health systems where we do ongoing monitoring and evaluation and see whether any change that we make had the proposed mechanism of making a difference that we intended. This is just to say that this started with a snowballing kind of effect of identifying stakeholders. We found a few people who we knew in Iquitos were key champions of public health and cervical cancer screening. We engaged women in the communities, the natural healers, community associations, a whole host of multi-level health system providers, multi-level providers at the different, there were 2 regional hospitals within Iquitos that would be primarily responsible for the management and treatment of either screen positives or women with cancer. The DIRESA, which is the regional administrative coordinator for the Ministry of Health Programs, the insurance scheme for those who were not insured by their employers, the Ministry of Health, financial staff, regulatory managers, and then the health network itself that we engaged with. And the first thing we did, and this is something that I think Peter was alluding to, is the best way to find good leverage for change in a system is to create a shared understanding of what that system actually looks like. And I think what I learned from this experience and what I have seen kind of repeat itself, and Peter can probably speak to this as well, is that even though we think we understand what a system is doing, when you actually get people involved at different levels of the system together to discuss it, you realize that they don't actually understand completely what each other are doing. And so we've started with the visibility of what were they currently doing to prevent cervical cancer through secondary prevention or screening. So they were either doing visual inspection with the acetic acid or pap screening. And for time, I don't have time to go into a lot of the details about these, the evidence base around these, but pap screening, if it's done frequently enough, has worked to reduce cervical cancer globally. VIA at the time had been shown in some randomized controlled trials to definitely at least reduce cervical cancer mortality. And those were largely studies in India, but they had some definite implementation challenges. If either of the screening tests were positive, then they were referred to the hospital. So the screening would happen in the primary health facility, referred to colposcopy at the hospital level. Either you would get a colposcopic exam that said nothing looks abnormal, we'll refer you back to routine screening, or we see something that may not be normal, we'll take a biopsy. And if it turns out to be precancer, we would, go on to treat it. So that was the system as it was defined, and if, looking back on it, pretty simple, right? These algorithms that we get from the international guidelines, pretty simple. Okay, well, when you actually say that's what you want to do, and when you move to the, well, how are you actually doing it? That's when we found that it got not quite so simple. And so we started, and I can remember, Ann Rossich, who's on the call, Valerie and I and others, were in one of our colleagues' offices in Iquitos, and we brought multiple level stakeholders together, and we tried to draw out, explain to us how you move from those steps. How do women get into screening? How do you know that they're positive? What kind of steps were taken? How do you get the positive test result back? Where did they go? And we came up, this was our original whiteboard kind of flujograma or, flow chart of how the screening was actually working. And what we could see is, I remember us sitting there thinking at the end of the day with our colleagues, we have no idea what's happening. This is just not as systematic as one might think. And so what we did then was to actually engage in a series of qualitative interviews across multiple stakeholders, where we literally looked through this kind of, this what you should be doing, and asked each of the individual stakeholders, where do you work in this part of the system? How is it working? Tell me how it works. If you are only working here, what do you think is happening at colposcopy, et cetera, et cetera? And what we got then was a much more complex flow chart of what actually happens versus the kind of what should be happening. And this was really an eye-opener, because it started to highlight what was then agreed upon by all the stakeholders in the system, where we had major delays in the system because of a variety of reasons. We had redundancies in the system. There were fragmentations, particularly between the primary level and the hospital referral, where people just didn't know what was happening. So it was very difficult to ensure that women got follow-up. And then in many places, there was no standardization of procedures. And so that was something that really got people to start thinking together about what their system actually looked like versus what they kind of thought it was supposed to look like. And then we went on to do some monitoring and evaluation prior to doing any kind of change in the system. And we were looking at, well, how well does that system as it is, the as-is situation, how well is it really working? We did an 18-month audit of screening, which showed stable monthly screening rates by VIA and non-pregnant women, which this was the general program in Iquitos at the time. VIA screening was what was recommended for non-pregnant women in Iquitos, and PAP for pregnant women. And what we could see in women 30 to 49 years is that they were only consistently meeting about a quarter of their monthly screening targets. And so they would, with either of these two tests, they would have needed to screen about 390 women per month. And they were only screening just over 100 or 150 women per month. And so this was clearly one of the reasons why the cervical cancer rates were not decreasing, is that they just weren't meeting their screening goals. We also looked at what happened once your screening test was positive, and we were particularly looking at the 193 over the 18 months monitoring and evaluation of the as-is situation of those who were VIA positive. 172 were investigated for hospital follow-up. We found about just under 40% had any evidence of follow-up, and only 30% of those did we determine actually completed the care continuum. And that meant that they actually had a positive VIA. They went to the hospital. We saw evidence of that. And then at the hospital, we saw some recording that either their colposcopy was normal, and so they were sent back to screening, that they had a biopsy which was less than precancer, and so they were determined not to need treatment, or they were defined as having a precancerous lesion or a cancer, and they were actually treated. 13 were lost to follow up at the hospital, so they either had a biopsy with no results, or they had a CIN2 plus histopathology and didn't get treated. And so at the end of the day, we had about 70% who were lost to follow up. And so that was clearly well below, the 30% kind of completion of care was well below the WHO elimination goals. And I'm going to just kind of quickly go through these slides. I'm happy to share them, but we went to a lot of effort to try to understand, why women were having low reach. Again, it was a lot of geographical limitations. Primary health centers were very well placed, but they had few staff who could actually deliver the screening and have the training. We did some qualitative interviews that is soon to be published, which is actually looking at why the women didn't go to their hospital follow-up. And one of the things that we heard often from the hospital providers is that, well, the women just don't know, they're not educated, that, that it was kind of a little bit kind of putting the burden of not coming on the patient. But when we went, we actually found out, no, they're trying to go, and the system is just not able to support them. And so we found a lot of really good information about that. So the next thing we did was to actually use then the shared understanding of that as a situation and how well it was or wasn't working in different levels. And that's where we applied what we retrospectively learned was group model building. So we actually had the different stakeholders engaged in looking at their system. Now, we did this in a slightly different way. We didn't use stock and flows or the causal loop diagrams, but we did more of things like swim lane visualization, so we could follow a patient through her continuum of care at different levels of care. So this would be an example of a woman who screened positive and what she had to go through just to get an appointment for colposcopy. And so that was something that was very enlightening, is that once you got to the hospital, the women really had a difficult time, often had repeat redundant testing. And then with the shared visualization of what was really happening in the system, the stakeholders sat together and said, okay, well, we've got an evidence base that was coming from the WHO, which says you've got multiple options for both screening to reach a 70% coverage goal, and whether you triage after a screen positive, or you directly send them to colposcopic or pathologic diagnosis for precancer, or you just immediately treat. And you can see that there are lots of decision points that go along here. And for time, I'm not going to be able to go through these. But what we did in the group model building process is to say, okay, well, if you had to consider, you've got these 4 different areas of evidence-based from which you can draw an evidence-based decision of adapting or adapting your screening program, which decision are you going to make? And we really probed them in these discussions of, well, would that decision be feasible? Would it be acceptable? And will it be acceptable to everyone, both those people who are going to influence the program in terms of giving it funding, those people who are going to deliver the program, and those people who are going to benefit from the program and the larger community. Importantly, of course, is would it be affordable? Would it be sustainable? And very importantly, is will it be equitable? Is it only going to benefit those who have the most access, or would it benefit the whole society, which is really what we need to do to meet these elimination goals of 70% coverage and 90% treatment. So one of the ways that we worked in this group model building process is we developed a very simple scenario tool, which actually allowed people to make different kinds of assumptions about how many people they needed to screen to detect how much precancer, how often they wanted to screen, what they thought their screening coverage would be in a different scenario, looking at the actual performance of the screening or the triage test, et cetera. And the idea here was to work together to have the stakeholders in the program actually do their own walkthroughs of different scenarios to see what the impact would be in terms of how many precancers were treated, how many might have been overtreated, and then what kind of resources would be required to deliver that program, with the idea that you want to find a solution that's acceptable to all, which is balancing desirability with feasibility. And one of the important things here is just acknowledging, and this is what I have found the real power in participatory group model building, is that you can see if this is the truth, right? It's a cylinder which is orange on the outside, blue on the inside. Depending on which perspective you're looking at that same truth, you may have only a very limited interpretation of your system. And so one of the things that this allows us to do is everyone to get on board with the same interpretation of the holistic system, so they could really understand what levers they could pull to make the system better. And so this is one of our early groups of participatory group model building. You can see we had really high participation. People actually do enjoy this. I think they really enjoy being asked for their opinion and to contribute to these decision-making processes. And what they did was they changed their primary screen from VIA or PAP to HPV testing, which allowed self-sampling, which they thought could improve the screening coverage. then if the screening test was positive, they sent them directly to a primary care facility to determine if they were eligible for ablative treatment without doing any kind of colposcopic diagnosis of precancer. If they were eligible, they were treated at the primary facility with ablative therapy. If they were not, only then would they be sent to colposcopy and for expert evaluation and treatment. Phase 3 is essentially what we typically think of when we do implementation research. So we had implementation planning teams, we had training teams, we had infrastructure development, and basically we did all of these things to actually implement a new program. And in phase 4, we actually used a variety of methods, including deliberative dialogues, implementation outcomes, and re-aim to basically look at, again, how acceptable was the change, how much did all of the different, beneficiaries or health services delivery staff actually adopt the change? Was it feasible? Could they do it the way that it was supposed to be done? What was the cost? Did the coverage change? And do we think it would be sustainable? And these are just quick results of what we saw. And so this was an implementation outcome by location of health facility. So this is one way of summarizing our data to say that if our pre-implementation goal for screening is 70%, which you can see with the dotted line, right? That every single urban, peri-urban, or rural set of primary health facilities were not meeting their goal. And you can see that after our implementation of the new program, which was HPV-based testing rather than PAP or VIA, every single group exceeded their goals, some by quite a lot. You can see that exceeding their goals of 70% screening coverage actually increased proportionately with how often the different health facilities use self-sampling, which I think is also evidence to the mechanism of why HPV increases screening coverage. It literally just becomes a lot more feasible to deliver. And you could see that that was especially true in the peri-urban and rural facilities where they had so many other competing requirements of what the health workers needed to do beyond screening. And so just being able to hand someone a swab to self-collect just became much more reasonable. The next thing that we looked at is whether the positives that completed care changed. And you can see here that prior to our intervention, that was, again, a result of the group model building exercise. That was a shared decision. You can see that of the 193 VIA positive women over 18 months of follow-up, only 30% completed care. When we task shifted, though, the follow-up of a positive HPV test, and note that we had now, 3 times more, a higher number of HPV positives in a much shorter time frame. This was only about 8 or 9 months. But when we could shift from the hospital to the primary health facility, we were managing to get, at the time of this analysis, 70% of women completing care. And I think Valerie will tell you that that's continuing to increase over time. And so I'm going to stop there, and I'm going to let Valerie then tell you just a little bit about what we've done to try to sustain this group model building approach and spread it beyond just this one health network in Iquitos to a broader Peruvian national plan. So Valerie, please.
Okay. Hello, everybody. Let me share my screen. And okay, so we've had experts talk about the bigger picture, theoretical, and as well as what Proyecto Precáncer did as an overall project. And it's been a long, complex process, but I'm now going to take us down to one example of using a group model workshop for one specific issue that we continued to see, that there was, despite the changes that Patty has just shared about increase of the screening and increase of the self-sampling and the role that played in increasing the screening, the sustained improvement in screening, even during COVID, even during pandemic, even through the fact that we've had so many different presidents in 6 or 7 years, we still have a problem, and that is we continue to have loss to follow-up issues at the hospital level of HPV positive women. So we felt we need to do something about this. So we're going to zoom in on this one problem, and let me go to my next slide. Okay, so this is the part of the picture that we're going to be looking at right now. We have our target population that's been screened, that's come for ablative therapy. They're referred to visual triage. They were deemed ineligible because either a suspicion of cancer or a cervix that could not be visualized. They were referred to specialists, and this is where we're seeing like they're not making it. What could be happening? So the first thing we did, and this is part of this group model building workshop, you know, as several of you have mentioned, and I even saw it in the chat, a lot of times it's easy to say, my reality or my view of what I'm seeing is that it's the patients who just don't bother to come. But if we start asking different players, we start seeing that, you know, there is multiple perspectives to this, and all of them have some truth. So our first objective of carrying out this workshop was going to be to share the finding of the barriers leading to loss of follow among HPV positive women. So for this, we had to understand key stakeholder perspectives on what the barriers were, as well as identify spaces in which change was possible. And they were the ones, it's their system, they're the ones who know their system the best, and we needed that expertise. So to start, before actually getting people together for this group model building workshop, we want to have as much data to inform the discussion and to make sure that the different perspectives were present. So we conducted in-depth interviews with 20 HPV positive women who required hospital level care. We did in-depth interviews with 12 health professionals who are doctors and midwives at the hospital and primary level before conducting our multidisciplinary group model building workshop with many of the health professionals, some of them that we had interviewed. And after doing these interviews, we mapped out what this swim lane visual looked like. You know, we had a patient who goes to a TVT, she waits for results, then she has visual triage, and if she can't be managed at the primary level, she's sent to one of the hospitals to get an appointment. But and we put this circular arrows because this process of trying to get an appointment was very complex, and sometimes there's no appointments and there's no equipment, and the equipment is malfunctioning, and there's no, the hospital's full. So this process takes many attempts, and this became visible for us in this process. So we started our group model building workshop by showing what had started emerging in this process. And interestingly, and I'm kind of jumping right ahead, but interestingly, we set out with one group. So after we kind of sat down with a group and said, okay, we need to talk about these things because there's a problem here. After sitting down, we had done a very basic model at the top that says the patient is not eligible. She's coming with pre-malignant lesions to oncology. She's getting her colposcopy with this doctor. She's supposed to get a biopsy and treatment, you know. And when we started our discussion, we got a small group out of a larger group together. We started our discussion and we thought, you know, these are the steps. So let's start talking about what is really happening. And we also started asking, you know, so the first conversation led to, yes, if they come, if they're referred and they have a HPV 16 or 18, they get scheduled for colposcopy within 2 or 3 days. And if the Dr. Luis can see that they need treatment, and if he clearly feels that this is a suspicion of cancer, he'll go ahead and actually do surgery even before the biopsy results are ready, because first it said biopsy to treatment, but then when you start probing, it's like, oh, there might be 30 days before you get the biopsy results. And all of a sudden, things started taking longer. So we started with this visual that seemed simple, and we started uncovering new issues. And that's what I want to share right now. So what were the topics that emerged? The biopsy results might take up to 2 months. So that idea that you could operate within like 3 or 4 days if it was suspicious of cancer, but why is the biopsy taking so long? Oh, because the pathologist is working at a different hospital. Well, why is the pathologist working at a different hospital? Because the pathologist was not being paid for his work at the main hospital. So then you start digging deeper and realizing that the underlying issue here that needs a long-term solution is consistency of provider payments, because people leave because they're not getting paid. Another comment that came up was like, oh, you know, cardiology, you know, when we need to do this treatment, it can take up to, you know, I can do it within a week. Okay, So you just treat them in a week, yes. But then we start asking, well, what do they need to do the surgery? Well, they just need a pre-surgical appointment. Well, what does this pre-surgical appointment consist of? Lab and cardiology. Okay, and so lab is done in 1 or 2 days. Okay, what about cardiology? Well, there we have a problem. Cardiology can sometimes takes us up to 6 weeks because sometimes there are no appointments left and they have to wait for the next month for the appointments to be made. And then the administrator may not have the whole scheduling. And so basically, during this discussion, it emerged by the people who were sitting at that table, yeah, it's really not that simple because we're having problems at cardiology. And so one of the director of oncology sitting there said, I'm making a mental note to myself, I need to really talk to cardiology director. Great, we wrote that down and said, let's follow up on that, Then they started talking about our different patient population. And they talked about, in Peru, and I suspect that we're not the only country in the world that does this, when you need to use blood from the blood bank, you have to contribute to the blood bank by using volunteers. So you bring in friends or family members. But indigenous patients who are there's a lot of different indigenous groups in this state, they come accompanied by an elder who may not be able to contribute to the blood bank, but they don't have a network in the city. What do we do? So that came up during this discussion as we're trying to solve the small problems facing like what we thought were 4 steps, right? So they came up like maybe we need to work with the blood bank to come up with a new system for indigenous, patients. Another issue came up as they were talking, and we were mostly observing, was, they have patient navigators for patients with TB and HIV. Why can't we have that for cancer? So we threw that question out to them. Why not? And so again, there was a list of things that came out of this. So something that seemed simple, like let's figure out a way to streamline this process. Patient gets referred, the patient gets an appointment, the patient gets seen. Turned out to be much more complex. And this is what I'm going to reemphasize what my 2 previous speakers have said. We need to acknowledge complexity in the systems, and we need to acknowledge that if the system is not working together, it won't work. So, when we talk about patients, some of the topics that emerge, who are the patients? Are they indigenous? Are they local? Where do they come from? How familiar are they with the system? How easily can they access the hospital? But it's not just the patient, because then they get to the appointment process and they have to take different paperwork. And sometimes they're not told what paperwork to get. Then they get to, everybody recognize that there's one midwife in the system that whenever patients were referred to her and she got them, she would refer them to her private center to do the follow-up. It's a problem because as long as there's a person who's referring them to their private business, like you're gonna be losing those patients and they have to pay. What if they're referred to gynecology instead of the oncology center, which is where the system is asking them to refer to? So how do we navigate the system? And then patients getting seen, are the providers there? Are they getting paid? Who is involved, and how do we streamline these processes? So again, I think what emerged in this group model building workshop was we presented a problem, we discussed it, we used those metrics that Patty was talking about, the Proctor implementation outcomes of what is feasible, what is sustainable, what is equitable, what can be done within this system. And this small group of individuals took ownership. They are now really becoming to be health champions of their own system. But other intangibles that came out of this small workshop, and this is only a part of the group. Another group was working on the referral and counter referral system. But what was other intangibles? We were engaging with bilateral exchange of information and knowledge and ideas. Trust is being built, like increased. This is like the 10th workshop that we continuously meet with these individuals, whether at a private level or in these workshops. So if anything, more and more people come because they know we come and we engage. We don't talk to people. We don't just talk down. We engage and we help build this collaboration and this teamwork. And we use a systems approach because we need to acknowledge complexity in the system. And I am going to finalize by talking a little bit about what I feel has been really important in this process. If you want to go fast, go alone. But if you want to go far, go accompanied. And I have this crab here because this project has been a crab walk to success, right? Every time you think you're moving a step forward, another thing comes up and it takes you sideways, and then a new cancer coordinator comes and it takes you a few steps back, and then a new cancer coordinator comes in and you move 3 steps forward, and it's been a constant back and forth of moving sideways, forward and backwards. We've had numerous barriers, and I know Peru is not the only country. We've had numerous barriers of multiple levels that has made the facilitating this strategy, this new a problem. Partnership between institutions has enabled a reliance that has allowed, like when one group was like under the limelight, the Ministry of Health could be working, or the regional actors could be working forward. When the Ministry of Health came to Loreto and said, you can't do it this way, they pushed back. They felt empowered. They had the knowledge. They knew what they felt that they knew what they were doing because they've been informed about literature and evidence. Our project also piloted this new strategy and generated evidence about acceptability of self-screening, about acceptability of thermocoagulation, and new tools and mechanisms, some of which Patty talked about, the scenario analysis that has helped people work through different questions. And now we are working with the Ministry of Health as they're scaling up in new regions of Peru. There's 12 new regions this year. We are participating in most of the planning sessions. Now Ecuador and Colombia are trying to do the same thing. And again, we are beginning to be engaged. And so this process has been snowballing forward, and we just wanted to be available to share some of these experiences.
Thank you so much, Valerie. Thank you, Valerie. Thank you, Patty. Thank you, Peter. So I'll hand it over to the director for the Center for Translation and Implementation Research, Professor Echezona Ezanole. Prof, you have the floor. Thank you.
Thank you. Thank you so much. And thank you. I am very, very excited. I was just busy taking notes. And it's amazing how you think things are simple until you start to actually ask questions. And then, and sometimes the funny thing is that you think you know. You actually come to this place thinking you know. You basically know. And the first thing you realize is just how much you don't know. And that's the first realization that made you realize. So we're really happy because we are at a point in Nigeria where we're trying to build an infrastructure for research, not just for one particular research, but really build a great infrastructure for oncology research. So we have various teams across the country that is doing this, and we are very grateful for NCI because we have four different teams in Nigeria funded to actually look at cancer. So we felt that this is an opportunity for Nigeria as a country to build infrastructure that lasts way beyond the funding. One of the challenges of developing country is that when money comes, we think that is to get the project done, and then after that, what next? So there is one of the things we talked about is sustainability. And the fact is that if you want to think about sustainability, you don't think about it at the end, you think about it at the beginning. So this is one of the things I'm learning here. I'm hoping that people can use the Q&A. So if you have a question, put it at Q&A. Thank you, Paddy. I think you're responding to some of them as they're answering them. So please put some of them. And Paddy, if you see anyone that you wanted to read aloud, you can read it aloud for everyone. But please put in your questions on the Q&A. I have a particular question since I am here and I'm struggling with this thing. One of the things I'm trying in my team to do is we have teams at different levels. So at the health facility, we don't have a lot of those infrastructure at the primary care level. So where we have them is at the secondary health facility. So we started with them. So we have a primary healthcare facility. Most of them are like clinics. They don't have a hospital. They don't have all the infrastructure. Then we have the secondary health facility. The secondary health facility are like general hospitals. So they have almost everything except the pure specialists. So we usually use them for a lot of the things. So we have the Nigerian Implementation Science Alliance. Those form our bedrock. So we have 21 of them across Nigeria, and we have that infrastructure built. Then, because we're divided into 6 regions in Nigeria, we have tertiary center at each of the region. In those places, we have each of those centers have an oncologist, a gynae oncologist, and a palliative care physician. So they have that 3-person team in now. So we built this structure. And the reason we're building it is that we're hoping that even when our funding ends with the research project, that we have built an infrastructure that we can use to improve care. So there are a couple of things that we notice, for example, that we use. And I want to be able to, I'm giving you a little background to understand some of the questions that I want to ask. Is that in Nigeria, for example, when we went in there, we thought that the doctors at the sites were the ones who actually do this VIA. I was very certain, but then we got in there, of the 12 sites we have, actually it was the nurses that were doing those things. So it wasn't the doctors. And nearly, we didn't even want to invite the nurses to the meeting because we think, the doctors are there. But actually, we find out that the VIA was done by the nurses. That's fact. And then and it's important that if you really wanted to find out what the challenges are, you want to bring in the people who actually do these services. So we actually have that meeting that coming up in 2 weeks. So this is why we wanted to have this before our meeting, because we are really having a meeting where we are going to try to use group building technique as a way. But the challenge we have is this thing that comes in implementation science, that you have to name it, you have to define it, and you have to specify it. And like Patty was saying, sometimes you do something, you don't even know a name for it. So that's why we're trying to say, okay, while we are going to have this meeting, we are bringing in all the doctors from the primary healthcare side. We are bringing in all the nurses from the primary healthcare side. We are bringing in all the study coordinators, and we're bringing in these 3 specialists at the teaching hospital. So we have a meeting of 90 people coming in one place from all around the country, and we're trying to do this. So you can imagine what we're dealing with right now, trying to figure it out. But we wanted to meet as a group, first of all, to build the group among ourselves, and then go back and continue to build that, but to be committed to building that infrastructure for the country. The question I have coming back to this is this: how, when you talk about this, how does this different? How does group modeling different? I struggle with it, with crowdsourcing. If you're doing a crowdsourcing and you're trying to trade out there to do it, how does it really? So Peter, I think you can go ahead and give me an explanation for this. I can name it a little bit. How does group building, how does it differ from crowdsourcing?
That's a great question. So the short answer, so both crowdsourcing and group model building have a implicit social epistemology. How are people learning and developing knowledge together? A big difference in group model building is you have, like what Valerie and Patty were sharing, you have these visual representations of boundary objects that people are reacting to. And there's something different happening there with the linguistics. People are negotiating what those symbols mean, and being able to reinterpret. And then with system dynamics, you're actually filtering in a sense. So you're bringing in a set of ideas, and then they're being filtered through in system dynamics, a feedback perspective. In crowdsourcing, it may be more lists of information, voting. Some of those techniques are used, but there's always sort of this approach of coming back to thinking about refining and the picture of the system as a working document. And there's more specifically some of the issues in terms of how you build up trust. The interaction, I think, is really key. I think there's some, when we've done group model building online, we don't have the same, we can do it, but it's not the same quality. And Valerie really had a nice list of the intangible benefits. So there's a lot that's happening in that face-to-face, which would be similar to meetings and participatory action research. But again, the focus is on this visual representation or boundary object. And I think that's usually how I would actually define the distinction between group model building and a conversation. It's the intentional design and management of those visual boundary objects in a group session.
So as you're saying it, I'm thinking in my mind with a follow-up to think, do you think one is better than the other when you are dealing, depending on the level of education of the people that you are dealing with? Does culture play a part to it? So for example, one of the things we are struggling in this meeting that we are trying to have, and we want to have a group building, but one of the things, model building, but one of the challenges people are bringing in, we want to put the doctor, remember we thought it was the doctor that was doing it, but we find out it's the nurse that's doing it, and we want to put the doctor, the nurse, and us researchers in a meeting. And some people say, that's not going to work. The nurses won't talk, So Valerie, it seems like you have yes, please go ahead.
Well, we had a similar situation in the rainforest. Most of our clinics don't have medical equipment. Many of them don't have doctors. And at minimum, they have what is called an obstetra, like a nurse midwife, except she's not a nurse. And they did all the reproductive health care. They were the ones in charge of pap smears and visual inspection with acetic acid. So when we started trying to move the system of this screen and treat to the primary level, lots of doctors, there's a lot of territoriality here for the doctors like, no, a nurse midwife cannot do the treatment. Even though they're actually the most used to seeing a cervix, they can't do the treatment. Fine. So we had to work with that strong push to make sure it was a doctor. Specialists did definitely not want the nurse midwife. But when we said, okay, we're going to train some primary level doctors to do this treatment, even though they weren't normally looking at cervix on a regular basis, that was found to be acceptable. And so we found a few champions within that primary level that were doctors that learned. The specialists watched them. They checked off when that doctor was ready to do it on their own. And that doctor then was very innovative and came up with, he became a health champion with that nurse midwife. They worked together. Now, not only do they do it at their primary health center, when you need to get them on a boat to go to communities down the river, he and this nurse midwife both take their little thermocoagulator and go down the river. And so they are implementing, they're empowered. They are doing, and they know that they have changed the system, that they are the first ones in Peru to start moving the type of care that is given and ensure an equitable access to follow-up. And this is really reminded to them all the time that not only did they do what the system asked them to do, not only did they get trained to do this, but now they're coming up with new ways to make sure other women are getting it. So we, as I say, we had a similar issue, but that was the solution they found. We just watched and gave some ideas here and there as equitable partners.
This is one of the things we have these teams all here today, and that's one of the things we are planning for this our meeting in April 28th. To be precise, we are bringing in teams. So from each of our 12 model sites across the country, we have 2 from each of the region. We are bringing in actually 3 people. We are bringing in the nurse, we are bringing in the doctor, we are bringing in our study coordinator, which in the same place acts as a patient champion and a navigator at that site. So we are bringing those 3 people. We didn't have enough funding. We would have brought in a very important person, which is our adherence counselor, because we are looking at HIV-infected patients. So I'm going to stop. I have a lot of questions for myself, but I think I'm going to make a personal call to you to help me in this meeting that is coming up. But let me let others talk about the question. The best way to ask questions, we are now going to give you hands by raising hands. We think to manage time better, put your question in the Q&A. We will read out the question and then we'll respond to them. So Dr. Onyeka, if you see any question there, read it out. We are not going to do hand raising. We think that kind of takes people time to talk that. Ask your question specifically in the Q&A. We'll read it out and then they will respond to it. So Dr. Onyeka, is there anyone you want to read out?
Most of them have been answered by Patty. Okay. Yes, especially I think one very interesting one that says the difference between the group model building and the FGDs.
Okay. I'll add a little bit to that response. I mean, for those of you who are experienced at doing focus group discussions, your facilitating skills will come very much in handy because it's about knowing how to use your body to get the conversation going, knowing how to look at people to make sure other people are contributing, knowing what size of a group is going to be conducive for having conversations, being participatory, having these small activities up your sleeve that if something is not moving forward, you can take them to, so those skills are useful. But I think, again, the focus or the objective of the meeting is different. With a focus group, it's all about you getting new data. With a group model building, it's about putting it in that room and saying, we're all in this together and we're going to interact together and we're going to talk together and I'm going to contribute what I know if I can, and you're going to contribute what you know, and together we will all come up with a better system that you guys own, No,
I think one of the things you said in the meeting was that group building is an intervention. And that's what I think actually differentiate them as I was listening from my ear as somebody who uses these different strategies and tools and models. I find the group model that you can use that to get information. But actually in the group building, you let them, they are going to be, it's almost like they have to be a solution. So you're bringing in the nurse, the doctor, and said, this is your challenges. come together, discuss it. How are you going to solve it? So at the end of the day, it's actually an intervention different from focus group where you just get information.
So let me ask you a question. Like in your system of care, how often do you guys have a space for reflection to think, what are we doing and what can we do better? Like how often do you stop and say, we've been doing this for 3 months, we keep doing the same thing, why don't we get everybody together and say, what strategies are you using that makes it work better? How often do we do that? And I suspect if it's like Peru, that you're going to say, we don't have time. We don't have time. So we keep shooting the arrows in the same direction. We keep missing the point because we don't take the time to stop, to spend 3 hours together and say, I'm in a different position. I'm in a different community and I've been trying this and this seems to be working for me. Oh, really? Well, let's learn, let's talk, let's share, let's discuss. And those reflection spots, like they really function as a group model building workshop because what you're doing is you're getting people to sit down, exchange information, think about what can be done differently, and then go out there and try that, test it out, and then come back together in 6 months and see if there's been any changes. But I think, and this is what has been so important in the Inspire framework that Patty shared. It's circular. You don't just say, we did it, it's over. It's more like, we all start exercising. We say, oh, I'm doing really well. And then you get sick, you stop exercising and you stop exercising. So you need to pick up that behavior again and again and again. So how do we make sure our systems have that space for reflecting, improving, and keep going?
So one of the things that we're trying to do, and I want to see if you guys have a response. Do you have another question? So if you have, I stop. Go ahead.
Building on. Okay, this one. So the whiteboard an integral part of the group model building?
I'm going to let Peter answer this, or Pat. I mean, I find it integral. We need some visual. Patty would say that. You definitely need a visual that everybody shares that visual. It's kind of like when you work with children and you have a toy in front of you and they get less intimidated. You have a shared visual where everybody can look at it and we all see it's not your problem, it's not your problem, it's not your fault. We have a system here and we all have to focus on that and we need to solve that problem. So whether it's a paper, a whiteboard, a pretty chart, or a graphic representative, but Peter, I don't know what you would say.
Yeah, no, that's a great question. I completely agree with Valerie. You need some sort of tangible representation. It doesn't have to be a whiteboard. So with FES, we very quickly drew on their experience using participatory rural appraisal. So we would use ideally use local materials, everything that was accessible. So that might be, in some cases, a mound that was representing a forest with sticks, for example, because that's what that was what was available in some of these cases. Yeah. Okay. But whiteboards work well. Flip chart paper.
So I think the whiteboard could, like Patty was saying, that it could be a piece of paper. We had a board, a real board in my place, and we had a chalk. So we did, and then finally they removed the chalk because we couldn't find all the time. We now use markers, and then so we've been trying to use. But I think the whole idea is to think that visual let people refocus, let people keep refocusing, and you're able to repoint people to the issue, so that as they start to digress, you refocus. As they try to digress, you refocus. So go ahead, Onyeka. Please put your question in the Q&A. We are going to stay as much as they want to stay. Go ahead.
There's another question that says, is it fair to say that group model building is similar to program evaluation in a way? Because it appears there must be intervals at which there's a check-in. So Valerie, do you want to answer?
Sure. I mean, we used it not so much, it can be used for multiple reasons, but to me, my use of this word is to create a new actionable, right? So when I think of the evaluation,
so more as an intervention, because I think let's name it more as an intervention than just an evaluation.
When I think of an evaluation, I think it as an endpoint, and yet life doesn't end when you change a behavior. Like it continues to go down, go back up, go down, go back up. So to me, a group model building workshop is about taking the time to step in and meet and see how things are processing and work towards streamline. So to me, it has a little bit more of an action point than just an evaluation. Like, did we meet our metrics? Did we get to do what we do? You know, it's not a checklist. It's like, let's come together to solve something together. But again, I'm not the.
Yeah, but I think Peter has an opposing view to that. Peter, you want to say
something? It's not an opposing view. It is actually different method. Peter, go ahead, please.
Yeah, I was just gonna, I mean, you can have you can use group model building for program evaluation, like needs assessment, or I've used it for developmental evaluation, but it's doing, in that context, it's doing the same thing. You're using it to learn, reflect together what Valerie's saying earlier. I think the key point is you have to be clear why you want to use it for group model building to be successful.
So I'm thinking about it that if you're going to use group modeling in terms of those things, I think in some of them you are not trying to change behavior. If I'm doing a focus group, I don't think a majority of focus groups are designed to change behavior. You're more trying to get information. If I'm trying to do a key informant interview, yeah, maybe I do that along the way, but my key thing is, again, to obtain information. I see, and I want to remove my ignorance here, so correct me so that I can change my mind. My mindset is that if I'm using group model, I'm thinking about people coming together to find a solution, so that they actually, they can bring out this information. So I link it more to a nominal group technique or concept mapping in a way that I think, yes, you bring out the barriers, but you also bring out the solution to your barriers. And then you try to achieve a consensus of how we are going to overcome these barriers. So it's not enough to tell me the barriers. It's not enough to tell me the solution. You are now saying, these are the barriers, these are the potential solutions, and this. So that kind of way, so you use nominal group technique within group model. That's interesting to see that. So that's how I see it. So, okay, I'm not totally ignorant. So I do understand some of what I'm thinking, that's helpful. Okay. So what other questions, Dr. Nyeka?
Yeah, so more questions. What extra skills might one need for the group model building if you've been using the focus group discussions?
I would say, personally, as someone who's done both, I would say the ability to in focus groups, it's really important to listen, right? The more you talk, the less you hear others talking. So, and I would say it's a similar thing with group model building. But maybe the difference is not what I want to know, but reflecting back to what people are discussing. So in a focus group, again, I see it as more directed towards what I am trying to get at. I am trying to learn about certain topic. In this case, I'm more of a mirror. I'm there to sometimes reflect back, or I heard this and I reflected back. Did other people hear this? And what do you want to do about this? How do you want to? So I would say that maybe the difference is your role. I mean, again, the skills are similar, but your role is different because you're continuing to focus on how the system, you're focusing back on them. And then also the action items are not about you. You're not the one who's going to go, the action items is figuring out who is the best person to take it forward. So I think it's more about the direction. As Patty mentioned, it's a bilateral engagement. You're really making sure it's going in all directions, that the people sitting at the table are the right people to be having this discussion. And maybe, if anything, my role is to keep asking, is this equitable? Is this feasible? Is this sustainable? Is this adoptable? And then let them come up with these decisions. So, but I think the skill set is similar. So it's just what you do with the information is gained.
Okay, this question says,
hold on, Nyeka. Hold on, Dr. Nyeka. Peter wanted to say something.
Yeah,
okay.
I just wanted to add, I think with group model building, in terms of the skill set, there's some activities you can do with the same exact skills and reflecting. And then what varies with time and experience is the tools you're using for that reflection and asking different questions. So as people get more into, for example, formal simulation modeling, they're asking questions and reflecting back on that conversation at a different level about the system. That builds up over time. So it's not like a yes, no, it's more like you can ease into it, you can draw on skills you already have, and then begin to build up your understanding of a system. And then with things like additional skills like model building, for example, and building formal models, those and experience that gets deeper.
So I have a question, just to follow up before Dr. Nyaka go for the next question, is to say, yeah, do you think that the group model should be conducted by a team rather than you would have been with a focus group where there is one person? And the reason it seems to me, it looks like, so for example, and I'm going to tell about myself, I know very much about focus group. I never do them. And the reason I don't do them is that I talk too much. So I'm not the perfect person to actually do the focus group. So I always find somebody who have a different demeanor to lead that focus group. But what I'm very good at is in the reflective part of it. Mm-hmm. It's not just about getting that. It's able to hear that and be able to reflect that. Yeah. So do you think the group model should be done by like a team when there is somebody who is able to let people talk, and then somebody who actually can in real time be able to pick those thoughts and reflect them back? Is that something that is conducted by a team or still like a one-person thing?
Group model building is teamwork, and there's a specific role called the reflector. And I think trying to do group model building as an individual it may feel like it can work, and then some exercises, but it's very challenging. And what gets lost is that ability to, you're managing a number of different things, the facilitation, you're managing actually the visual object, and then you want somebody who's really who's getting ready to reflect and pull out insights, who's observing. Sometimes we have process coach, recorders. So George Richardson, David Anderson have a paper on teamwork and group model building that lists out those roles.
I want to add to that, and Patty mentioned this in her presentation, that we started doing a lot of things because they were intuitive. They made sense. It made sense for us to do the next step. And we didn't know we were doing group model building, or we didn't know we were doing like different. And as we look back, for example, there's a framework that's used in implementation science called the Consolidated Framework for Implementation Research. When we were starting, it didn't make sense to me. We needed like a process model. Now I look back and I say, oh, now it makes sense. So I would say, don't be afraid to start. If you look at the visuals that we had when we started this project, and you look at our visuals now, we've come a long way. We started learning ways to make the data more visual. We started learning to, the scenario analysis started off with sticky notes, and it finished up with more like an app. But we needed to start. We needed to see what worked with people. Like as we were doing these tools, we said, this tool is a little complicated the way it is. If we only did it this way, it might work better. And so in the next workshop, we did it slightly different. And we saw that people got it. Okay, so then let's make this one even bigger. So I would say like start. A lot of this is somewhat intuitive. Keep in mind that, as Peter says, if you have a group, you can balance each other out and say, let them talk, or you work with each other on doing that, but don't be afraid.
Okay, thank you. Yeah, so there's two other questions. Someone says, where is the position of paramedics other than doctors, nurses, laboratory scientists in this group model building? So where's the position for other healthcare workers?
I think it depends on your system. So our system didn't have paramedics. Last time my mom here in Lima called the ambulance, they said it would take 3 hours to get there. So she took a taxi to the hospital. So that's our system. In Iquitos, I don't know if we have paramedics. So again, your role is to figure out who are your key stakeholders, who are the key actors in your system, what role do they play, who are you missing, are you sure you have everyone that should be sitting at the table, and start figuring out who is playing what role, and make sure that this is visible in your system so that you understand like the full picture. When you think that it's only based on this, and you left out a key player, I always use the example of like blind people touching an elephant, right? If one person is touching the trunk, is that how you say it in English? The trunk,
right?
Yeah. and one person is touching the tail, and one person is touching the stomach, and you're all seeing different parts of the system. And if you don't have all the different players involved, you might get the wrong picture of what you're dealing with. So we didn't have paramedics. You do. Figure out where they belong in your system. Figure out if they are the ones who need to be sitting at the table when you're having these discussions.
Okay, thank you. Then the last question says, what informs the selection of scripts for the group model building?
So
I see, but yeah, go ahead.
I mean, you can, so the scripts, the key thing with scripts is some are divergent, they generate ideas, and others are convergent, they're bringing ideas together. So you want to, in terms of the selection of the scripts, there are certain, you want to be alternating between divergent and convergent. There are also some examples of certain sequences seem to work really well. So if and tend to be like a go-to in terms of a pattern. So it doesn't mean you have to stick to a certain sequence, but they're reliable. And I think if you're asking questions about sort of like which scripts should we use, what sequence, I think talking with folks who have used the scripts and figure out what works and what's realistic is helpful.
I was going to say that if you look on the chart, you also see some of the resources that Patty put there about the work Peter has done in terms of scripts. We are going to make those resources available on our website so that you can also take a look at them and be able to take a look at them. But I do think the last thing that you said is very important, and that's what we are intending to do, is that when you're doing this, I always remind people that everybody needs a mentor. No matter what you've done, the best mentor is someone who have done this, because then you don't have to make the mistakes they made, and you can learn from them. So we have, this is something that we want to be able to do. I like the group model building because of, in my own opinion, the extra thing that it brings in terms of we started with focus group before. We went on to nominal group technique. Actually, we've done a normal group technique in a way that we can now do it during the COVID period. We actually perfected how to do it virtually. And we've done that well with using Mentimeters and things like that, so that it's very interactive in the way it's done. We have our annual meeting at the Nigerian Implementation Science Alliance. We use nominal group technique. It's almost like running 10 different focus groups at the same time. So we have each table of 10 people, and we have different people. We have providers, we have policymakers, we have funders. So each table is mixed up like a focus group. So you have 10 people per table. And then, so when you have 10 tables, that's 100 people. So when we use nominal group technique and say, all the tables, we want you to come up with all the barriers. Then we want you to rank the barriers 1 to 3. We want you to bring the 3 from each of the table. That's 30. 3 times 10, that's 30. Then we project those 30, and then we start to rank them again. So we are bringing in concept mapping, bringing in focus group, all of those things in there. And I think where I think about it is that this is a progression, and at the end of these ideas you generated, you should allow a space for group model building and be able to look at those things so that becomes an intervention. People leave the place with actionable steps of things they can actually do to overcome the problems. This has been very useful to me. I hope it has been to a lot of the people who have been listening. And I really want to thank you. Dr. Nyak, is there any other question that is many that I have to take?
No, there isn't. There isn't. Thank you so much. Thank you so much.
Thank you so much. I'm asking that if we do reach out to you, please help us build up this system. Peter, we are going to be listening to you. Valerie, we are, because your experience, like you're saying, you are in a place that looks more like the place that we work. One of the things I'm learning is that it's not about what we should be doing, because it's what is actually happening. I realize a lot of the times we are focusing on what is ideal thing should be doing, and then we end up, because the ideal thing cannot work in these circumstances. Context is important. And that's where, instead of asking the question, what should we be doing? First of all, what is happening? What is being done? That forms there where you can see where you can make the changes. Maybe down the road, you get to the point where it's very, like for us, if you ask Nigeria to do HPV testing, very good, but it's not yet there. But we're getting there, because almost all our centers have the Gene X machine for TB. So when we are finally going to solve the problem, it's going to be TB infrastructure that is going to help us by using those things to do the HPV. But right now we are not there. So our VIA becomes the best thing everybody can do. The nurses can do it. So, but if you go there and change it, you might not be able to catch up with the system. So understanding what is actually going on at this time is something that's very important. This is very good for us. I hope that you'll come back. We will invite you again. We enjoy this a lot, and I like the way that we actually heard about how these things are, the theories behind them, be able to see an example of how it was used already. And this is a model of things that we're going to be doing forward. Thank you so much, Peter. Thank you, Valerie and Patty. Thank you so much. Thank you. Thank you. Thank
We're
you
all
so
in
much.
this together, so very happy to continue talking.
Thank you.
Thank you, team. Thank you so much for the email. Thank you, because I know many people will be reaching out to you guys with more questions. Thank you. It's a wonderful webinar today. Thank you, everyone, for attending, and see you next month. Bye-bye.
Bye.
Yep. And for all those people who attended, if we get any slides shared by the speakers, we will share it with you also. Thank you.
Yeah. Thank you.
Thank you.
Bye.
So, Dr. Nyeka, we would like to save the chat.
Okay.
So that if ask the team to save the chat before we end.
Okay.
I think it comes up after you end, then you're able to save the chat, but let them save the chat.
Okay. They have heard, they will, and I'm saving the chat myself.
Yeah, this was very good. This was really very good. I hope people enjoyed it as much as I did.